right-hand corner, sorry, on the top right-hand corner, you can see that sensor. You can see that really fine little filament. That's what's reading interstitial glucose under the skin. And then there's a transmitter, which is that gray piece on the top. That gray piece is good for 3 months. So if you ever have a patient in your ambulance and their sensor falls off, please don't throw it away. That transmitter is good for 3 months, and insurance is terrible at replacing them. You can see that with the Dexcom, people can see their blood sugar on their watch. They can do it on a handheld device. They can see it on their phone as well. So that Dexcom is worn for 10 days. People can dose insulin off blood sugar. It doesn't require them to poke their finger for blood sugar at all. They can use that receiver. They can also do the app on their phone. If they do an app on their phone, they can share their data with up to 10 people. So you might be transporting a patient, a teenage patient, that has a Dexcom, and parents might know what their blood sugar is doing, even if they're not in the back of the ambulance with you, as long as that phone is nearby, okay? Each patient can program their own high and low blood sugar alerts. They can also turn them off if they want to. The Dexcom does work with both the Tandem pump and the Omnipod 5. It reads a blood sugar every 5 minutes. It is approved for 2 years and up. Sometimes we use it under the age of 2. And that MAR data is just the mean accuracy rate data, or how good, how accurate is it? And again, that transmitter is good for 3 months, so don't throw that away if you ever have one fall off in your rig. There is a Freestyle Libre 2. It is a 14-day wear. You can dose insulin with it. You have to have a receiver or an app on the cell phone, and you have to scan it in order to get a blood sugar level. If you don't scan it, you don't get blood sugars, okay? It's about the size of 2 quarters stacked, so it's pretty easy to kind of hide under clothing. It is approved for 4 years and up, and we can, as healthcare providers, we can see it by logging into a website for that. Just this past summer, Freestyle launched the Freestyle Libre 3. It is also a 14-day wear. It is quite a bit smaller. It's about the size of 2 pennies stacked up on top of each other. You no longer have to scan it. You have to scan it once to start it. Otherwise, you don't have to scan for blood sugar data. And the only way you can see it is with a smartphone app. So if you have a patient in the back of your rig and you want to see their blood sugar, you'd have to get their smartphone to take a look at that. There is some medications like vitamin C or salicylic acid that can give false blood sugar readings if in high doses on those. So those are pictures there of the Freestyle Libre 2 and 3. You can kind of see the comparison on that arm. The Libre 2 is the bottom one, and the Libre 3 is the newer, smaller version. Medtronic has a pump. They also have a sensor. It will work with a lot of their newer models of pump. It does require you to still check your blood sugar at least 2 times per day to calibrate that pump and sensor, which for a lot of kids, they love not having to poke their finger anymore. And I don't know if you've ever poked your finger with those Lancet devices. It is not fun. And there's kind of looking at the Medtronic pump and sensor together. Just for 8th, the Dexcom G6 or G7 was approved. It just came out on the market today, actually. It is a 10-day wear. It's supposed to be more accurate. Will be eventually hooked up to the Tandem and Omnipod 5 pumps. It is not yet. It's a quick warm-up period. And then it allows patients, if it's going to expire, it gives them 12-hour grace period to replace, but it's quite a bit smaller than the G6 sensor is. So on that top left-hand corner, you can see the differences: G7 on the, or G6 on the right, G7 on the left. If any of you have watched the Super Bowl, Nick Jonas was wearing G7 and doing an advertisement for that. So when somebody is wearing a sensor, depending on, you know, whatever device they look at their sensor at, it will give them directional arrows. Is their blood sugar staying steady? Is it going up slowly? Is it going up fast? Is it falling fast? Or is it just falling down slowly? Which is really nice because they can look and see, how did my insulin affect my blood sugars? How did this food that I ate, how did that affect my blood sugars? They can try to catch a low before they get too low and start treating it, which is really nice. It has made diabetes management significantly better for families and patients. So now one of the nicest things that come out is they've incorporated pumps and sensors that work together. So we have the Tandem or T-Slim pump. Tandem's the company, but T-Slim's the pump. You might hear those used interchangeable. They have a program called Basal IQ, which is their older program. They also have a newer program called Control IQ. So when the pump and sensor are connected together and working together, on Basal IQ, it'll adjust the background or basal insulin up and down on its own for a target blood sugar. When they're using Control IQ, it'll still adjust their basal, but also as their blood sugar starts to go up, it'll give little micro boluses of insulin on its own to try to bring that blood sugar back down to a target of 110. So for those patients that did everything right, they gave their insulin and yet their blood sugar still climbed because they ate pizza or pasta or food that wreaks havoc on their blood sugars, this pump will help try to control that and bring it back. So I've seen patients that even miss boluses, meaning they ate some carbs, but they didn't give insulin for it, that still are managing to have their A1Cs in the 5 to 6 range. So below diagnostic, even missing boluses because this pump is doing some work for them. I've also had a lot of teenagers that I've seen for years, young college patients, that have said the Control IQ system has made them feel like they don't have to think as much about their diabetes anymore, which is really good because type 1 diabetes, these kids are at high risk for depression. So there's also the Medtronic 630, 670, and 770 pumps that are sensor augmented. They work only with the Medtronic sensor. And then this summer, Omnipod 5 came out, which again is a tubingless pump, but it works with the Dexcom sensor. Both the Medtronic and Omnipod pumps will adjust the background or basal insulin for these patients on its own. This is some pump data. We won't get too much in this, but what I want to show you is this picture. Hopefully you can kind of read this. So that squiggly line kind of on the top that's blue and green and red, that's the patient's blood sugar on the sensor going up and down, okay? If you can see kind of below that, there's some vertical lines that are going up and down, and they have a number above and a number below. That number below is the patient entering carbohydrates into their pump. The number above is how many units the pump calculated to give them, and they push the button to give it, okay? If you look just a little bit below that, you can see a solid blue line. And then you can see some blue vertical lines going up and down, and then sometimes some white spots in there. So that blue line going up and down means that the pump is automatically increasing the basal for the patient on its own, okay? The solid blue line is where we have their rate set. Now, if you see kind of where it goes white below that solid blue line, that means as the blood sugar came down to a low or got lower, the pump started shutting down that background insulin and might even shut the insulin delivery off altogether, okay? You can see there's a lot of black boxes. There's a few on this one. There's a few black boxes with little white teardrops. That's the pump delivering a bolus amount of insulin on its own because it sees that the blood sugar is a little bit higher than it'd like to be. And so it's gonna correct a little bit to try to bring that blood sugar down. So it's doing a lot of work in the background that patients don't even realize. Here's our Omnipod 5 data. This one isn't as impressive. You can kind of see those purple vertical lines or when patients are entering or getting a bolus amount either for a high blood sugar or carbs. The red and yellow on the bottom is kind of showing us that blood sugars are high and the basal is either kicking up or kicking down for them. Here's your kind of our Medtronic pump data. And we'll look here, you can see that sensor tracing, kind of the average sensor tracing up there. On this, if you look at the pink on the bottom, the pink is, as it's going up, means that the basal is turning up on its own. If it's coming down, then the basal is shutting down. And that's just trying to help kind of get those blood sugars as even as possible. But you can see even with a pump working in the background, blood sugars can be quite variable in patients. So one of the big risk factors of type 1 diabetes is diabetic ketoacidosis. Usually it's related to they're either missing insulin, either because they're way undercounting carbs, or they're just plain not giving insulin. They might have had, if they're on an insulin pump, their site might have come dislodged or got kinked under their skin, and they didn't know it until they wake up in the morning and they're severely high and throwing up. And so that's a big risk that we end up putting them in the ICU on an insulin drip, but they can die from diabetic ketoacidosis. So you may have a call on a patient that's looking very poorly. If they call us, and the first thing I ask parents is, how does your child look? And if I had one mom say, my child told me they feel like they're going to die. I don't ask anything more. I don't try to treat them over the phone. I tell them, you call the ambulance or you take them right to the emergency room. Okay. Another risk similar to type 2 diabetes is they can damage their retina in their eyes. They can damage their kidneys. They can have neuropathy, and it can lead to heart attack or stroke. And this is not an old person problem. I had a mom tell me one time that she worked in a nursing home as a social worker, and they had a 21-year-old that chose not to take care of her diabetes, and she had had a stroke and was going to be in the nursing home the rest of her life. So it is a possibility for a young person as well. They can have joint mobility issues, and it can affect their height and weight and how they grow. I tell a lot of kids, if I see your growth stopping, my first thought is your blood sugars have been high, especially when you're still supposed to be growing. Usually diabetic ketoacidosis, we see that if blood sugars are greater than 300, they'll have ketones in their urine. And then they can have they can have acidosis as well. If any of you are familiar with ketone testing, we usually have them pee on a stick. There is blood ketone testing that you can do as well, but generally we teach them to pee on a stick, and then they have to read it against this thing that tells them if they have ketones, small, moderate, or large. Persistent vomiting is one of the signs for diabetic ketoacidosis. Again, that Cushmall's respiration or that fruity odor to their breath. Abdominal pain. A lot of times patients will go into their primary care and with abdominal pain. And a lot of times they'll say, check ketones before you go in, because ketones, positive ketones with high blood sugars, can cause abdominal pain. And if we get their blood sugars down and clear their ketones, the abdominal pain will go away. They can get very drowsy, and they can actually, like I said, they can die due to cerebral edema from diabetic ketoacidosis. So it is our biggest cause of hospital readmissions with type 1 diabetes. You can prevent that, although sometimes the stomach flu can cause them to go into DK. Again, illness, we talked about causes for that. They do need to go in right away. If parents call and say, I can't wake my child up, or they can't stay awake when I'm talking to them, that they need to go in right away. That is not something we're going to try to treat at home. If they're doing okay, we can treat them from home sometimes and try to prevent them from needing hospitalization. When they go to the hospital, they'll get IV fluids. They'll give them, believe it or not, sugar, even though their blood sugars are high, but they also will give them insulin. And it's kind of a slow process. They don't do it too quickly to bring those sugars back down, but they do both sugar and insulin at the same time. IV fluids is really important. We usually use normal saline. They do sometimes use Ringer's lactate, but usually normal saline about 10 to 20 mils per kilogram in an IV bolus. We got to be careful not to over fluid them, or you can cause brain swelling and death. So it's a fine line there. We usually don't give them anything to eat or drink until they're out of their diabetic ketoacidosis. They will generally need an insulin drip. And that'll usually be continued until their bicarb level is above 15. If they are developing cerebral edema due to DKA or too much fluids, they might have a headache. You can have a change in their consciousness. Their pupils might be unequal and dilated. They can have incontinence and vomiting. They can have a low heart rate. Some other risks to talk about with type 1 diabetes is, again, depression. I will tell you divorce rates are high in our pediatric population because some of it is the fear, finances. Type 1 diabetes is not a cheap disease to have. And unfortunately, and I don't understand why, but the cost of insulin has gone up astronomically. The two gentlemen that invented insulin sold the patent for $1 so that everybody could have this life-saving drug. Several number of years ago, a vial of insulin cost $40. That same vial of insulin nowadays can cost $400. So if anybody can figure out why, please let me know. You know, some parents fear highs, some parents fear lows, and so that can cause a lot of issues. Again, with some of our diabetes technologies, patients don't have to have as big of bags anymore, but they still require to carry a lot of things with them to take care of their diabetes. Some other autoimmune diseases that you might see with type 1 diabetes. I don't know if anybody's familiar with vitiligo, but that's where they have, they lose pigmentation in patches of their skin. So you might have patches of white, really pale white skin in patients. I see it more in boys than I do in girls, but it's still in girls sometimes. Thyroid disorders like hypothyroidism is very common in patients with type 1 diabetes. The next most common thing we see with type 1 is celiac disease, which is an intolerance to gluten found in certain grain products. And then I have some patients with rheumatoid arthritis, Crohn's or ulcerative colitis or lupus can be common also with that, but I don't see those as often. And, you know, I would tell you, all of my patients would love to say one day that they used to have diabetes. Any questions?
Karen, we do have one. Actually, I don't have it on this chat box. Corolla, you want to ask your question? No, maybe not. I guess the question was, are you guys seeing, some issues? Oh, here it is. Okay. With the number of folks who are using injectable prescriptions for weight loss, such as Ozempic, and that one right there, that word right there, it is more and more difficult for type 2 patients to get their medication, and it's a fight for with insurance. So are you guys seeing some of that stuff too?
So I'll be honest, I don't manage type 2 diabetes, and we don't see it as often in the pediatric population. And so some of those meds wouldn't be used in pediatrics. I will tell you, it's a fight with anything with diabetes to get supplies. We fight with insurance companies to get sensors. Even though we have proven to a lot of our insurance companies, South Dakota Medicaid is one of them. We've tried working with them. We showed them that patients on a sensor, it doesn't matter if they're on a pump or if they're on insulin injections, if they're on a sensor, their A1Cs are improved. And so we still can't, they have to meet all the criteria still in order to get sensors. Certain insulins, you know, there are some insulins that I think are better than others, and it doesn't matter. Insurance tells us what they can use. The only time that we can get insurance to maybe write for something else is if they had a reaction to the insulin that insurance requires. It's not uncommon. I always tell patients, be prepared when it becomes formulary change time. So for most people, it's either January 1st or July 1, right? When our insurance companies start over on the new year. And insurance might change. So one year the patient might be using Lantus as their basal insulin, and then the next year insurance says they have to use Nuceiva, and then the following year they might use Lantus again. Same thing with rapid acting insulins or blood glucose meters. Insurance will tell them what they have to use. Doesn't matter what the provider says anymore, even if we think something's better for them.
Okay, thanks. We got any other questions? Well, thank you very much, Karen,
All
for
right.
doing this.
Yeah.
Really appreciate it. And yeah, it was great. Enjoyed it a lot. Some good comments coming in there. So that's awesome. Thank you
All
very
right.
much.
Well, you guys
and
have a good night.
Thanks. You have a good weekend.
You too. Thank you. Enjoy the rest of the conference.
Thanks.